Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the deep dive. Today, we're really getting into something quite fundamental. The structured syllabus, you could say, for performing precision surgery while, fighting your body's natural instincts.
That's right.
We're embarking on a deep dive into mastering laparoscopic skills. It's this necessary journey, isn't it? Taking a surgeon from basic psychomotor development all the way to real independent practice mastery.
Absolutely. And, this exploration is specifically for you, the surgeons and doctors listening, who are really committed to perfecting your craft in minimally invasive surgery. We're digging into the sources to map out that exact structured pathway.
Moving beyond just getting through a case.
Exactly. To performing it with, world-class efficiency.
Okay, but first, we absolutely have to state our critical advisory. This content is purely for reference. You must always follow your local guidelines and the established clinical practice protocols at your institution.
Your clinical judgment always comes first. That's paramount.
And we should also mention, this deep dive is presented by the Surgical Edge podcast.
That's us.
Okay, let's unpack this. Starting with that foundational shift, the mindset change, really. We have to acknowledge, don't we, that the second you switch from open to laparoscopic surgery, you basically give up 3 major sensory anchors your brain normally relies on.
Oh, completely. They're just gone. And that really defines the initial challenge, the barrier to entry for minimally invasive techniques. The surgeon has to shift from this immersive 3D, very tactile world to operating on a 2-dimensional screen. It becomes visually dominant.
So let's break down those 3 specific losses, the ones the surgeon's brain has to learn to compensate for or maybe even ignore. Okay.
The first one is probably the most obvious. It's the loss of 3D vision. You're looking at a flat 2D screen, so your natural depth perception just isn't there.
It's gone.
Gone. So your brain immediately has to learn new ways, new visual heuristics, basically. It starts calculating distance based on, say, relative size of objects on screen or interpreting shadows, and, crucially, using parallax.
Parallax, you mean that little controlled movement you make with the instrument tip? Exactly.
To gauge how far away it is from the tissue.
Precisely. And if your movements are jerky or, inefficient, you lose that subtle visual feedback that helps you predict depth. You really have to learn to rely on the texture you see on the tissue, the consistency of your own movements, to regain that spatial awareness.
So depth perception becomes this calculated visual thing rather than just instinct.
That's it, exactly. It's a learned skill.
Which must add quite a bit to the cognitive load. And then there's the second major challenge, the mechanical one, the fulcrum effect.
Ah, yes. This is where instinct actively works against you. The abdominal wall, where the trocar goes in, acts like a fixed pivot point.
Right.
So think about backing up a trailer, maybe. Turn the wheel one way, the trailer goes the opposite. It's similar here. You move your hand up outside the body.
The instrument tip inside moves down.
Right. Hand left, tip right. It's inverse.
It feels completely wrong at first, I imagine. The sources emphasize that you can't just consciously calculate this inverse movement every time. Why is making it automatic so critical? Well, because every conscious calculation adds a tiny delay. Milliseconds? Maybe.
Yeah.
But in a complex dissection, those milliseconds add up very quickly. To get that smooth, efficient, economical movement, the fulcrum effect has to become, almost subcortical. Second nature, truly. Your brain needs to bypass that conscious translation step altogether.
Okay. And the third loss. This one seems directly tied to safety, reduced tactile feedback.
Yeah, this is what some people call operating with remote hands. That amazing tactile sensation an open surgeon has, feeling the subtle difference between an artery and a vein, or judging just how much force to use when grasping delicate tissue like the liver capsule.
Right.
It's largely lost. It gets dampened traveling up the long instrument shaft. So this forces you to rely almost entirely on visual feedback for handling tissue.
That sounds particularly risky when you're doing something like suturing, if you can't feel the tension building up.
Yeah.
How do you avoid tearing the tissue or breaking the suture?
You literally have to see the tension. You watch for the subtle visual cues, maybe the tissue blanches slightly, or you see a tiny deformation in the anatomy as you tighten. That becomes your tension gauge.
Wow.
It demands incredible fine motor control and, honestly, a slow, very measured approach initially, because you don't have that safety net, that feeling in your fingertips telling you you're about to reach the breaking point.
Okay, so understanding that huge cognitive and sensory shift really lays the groundwork. Let's move on to how the physical setup impacts everything. Ergonomics. Poor setup seems like it could just cancel out good technique.
Oh, absolutely. Ergonomics aren't just a nice to have. They're foundational. They're crucial for preventing fatigue and maximizing your efficiency, especially in those really long, complex cases. The core principle is what they call patient-operator screen alignment, meaning the target area inside the patient, the monitor you're looking at, and your own body should ideally form a straight line.
And if that line is broken, what happens then?
Well, if you find yourself twisting your body or constantly craning your neck to see the screen, you're introducing muscle tension. That can lead to microtremors in your hands and, over time, even chronic musculoskeletal strain.
Makes sense.
And a surgeon who's physically uncomfortable is going to get mentally fatigued much faster. That directly impacts your efficiency and increases the risk of errors, particularly in that crucial last part of a difficult case.
So it really is about conserving your physical and mental energy. And how should your body actually be positioned relative to the operating table and the ports?
Ideally, you want a straight back, keep your shoulders relaxed, not hunched up, and importantly, keep your elbows fairly close to your body, with your forearms roughly parallel to the floor.
Okay.
This lets the instruments enter the trocars at a natural angle without you having to strain or reach awkwardly. And this ties directly into trocar placement.
Which, the sources really hammered home as being maybe the most critical factor for how smoothly a case flows.
Absolutely critical. The ports have to be placed to allow for optimal triangulation. Imagine the target organ is the top point of a triangle, and your two main working instrument ports are the base corners. They need to be far enough apart to give you room to maneuver inside, but not so far apart that your instruments are coming in at extreme angles or making excessively long movements.
And if the triangulation is off, that's when you get that dueling or fencing with the instrument.
Exactly, that dreaded fencing match inside the abdomen.
And what's the real cost of that, beyond just being annoying?
The cost is time and wasted energy. Poor port placement forces you into inefficient, long, sweeping movements, sometimes outside your main visual field. Or you're constantly fighting to stop your instruments from clashing. The total path length your instrument tips travel can skyrocket. Which directly translates to a slower procedure, a more exhausting one for the surgeon, and ultimately a potentially less safe operation.
Okay, that really clarifies the mindset and the physical environment needed. Now let's pivot. Let's get into the specifics of that structured pathway to actually achieving mastery.
Right. And what's fascinating here is that mastery isn't just about doing lots of cases or being senior. It really requires this systematic cycle, learning, deliberate practice, applying it, and then honestly reflecting on how it went. The sources lay out 4 pretty distinct phases for this progression.
Okay, phase 1. This starts well away from the operating room. Cognitive prep and basic psychomotor training. This is the simulation phase.
Simulation is absolutely non-negotiable now. You typically start with what are called low-fidelity box trainers. They might look simple, even basic.
Yeah, just a box with holes and a camera.
Pretty much. But they're incredibly effective because they force you to master those core competencies without the pressure of the OR. The classic task everyone knows is the peg transfer.
Right, moving little rubber objects from one peg to another.
Exactly. It seems simple, but it explicitly trains precision. It forces ambidexterity, using both hands smoothly and critically. It drills in compliance with that fulcrum effect. You have to operate looking only at the screen, just like in a real case.
And beyond just moving pegs, what other basic tasks build that foundation?
Well, there's pattern cutting, using laparoscopic scissors to cut along a defined line, which really hones your fine motor control and your reliance on visual feedback. And then there's the whole progression of knot tying. That's a big one.
Starting simple, I assume.
Definitely. You have to master the basic extracorporeal knots first, where you tie the knot outside the body and slide it down. Only after that can you really tackle the much harder task of complex intracorporeal suturing, tying knots entirely inside the body. That's often seen as the gold standard of laparoscopic dexterity.
Now, there's a significant cost difference between those basic box trainers and the high-tech virtual reality simulators. How do the sources justify making VR mandatory when you could just spend more time on the cheaper boxes?
The key justification is objective metrics. Data. Systems like LapSim or Symbionix, they capture things the human eye just can't track accurately. They measure your instrument path length, literally how far your instrument tips traveled, showing wasted movement.
Okay.
They measure your economy of movement, how smooth you were, and they log your specific error types. A box trainer basically tells you yes or no. Did you complete the task? A VR simulator tells you exactly how efficiently or inefficiently you did it. It gives you hard data, benchmarks for improvement.
And all this physical practice needs the mental side too, right? Cognitive rehearsal.
Oh, absolutely mandatory. Mental simulation. When you watch videos of expert surgeons, and you should watch a lot, don't just passively observe what they're doing. Actively analyze why.
Like why that instrument choice?
Exactly. Why that specific instrument right then? Why did they choose those exact port placements for this anatomy? Try to visualize yourself performing the procedure step by step. Even mentally rehearse how you'd handle potential complications. It helps prime those neural pathways.
Okay, phase 1 is simulation and mental prep. Here's where it gets really interesting. Phase 2, making that transition from the controlled sim lab into the actual integrated operating room experience.
Right. And your initial role in the OR, often as the camera operator, is actually a golden learning opportunity. It is absolutely not a passive job.
Just holding the scope still?
No. A good camera operator is a strategic partner. You have to learn to anticipate the primary surgeon's next move. Know when they'll need you to zoom in or pan out or reposition slightly, or even when the lens needs cleaning, ideally, before they even have to ask. You allow them to maintain complete focus on the task.
And in doing that, you're learning the anatomy from that specific laparoscopic viewpoint, which, like we said, can look really different from the open perspective.
Precisely. You're building that internal 3D map from the 2D view. And then when you progress to holding retractors, you become the active assistant. This isn't just pulling stuff out of the way. No, thoughtful, proactive retraction is key. You need to understand the surgical goal for that specific step and expose the critical structures effectively, but gently, without causing accidental injury yourself. And after the case, reflection is vital. Ask good questions.
Not just how did it go?
Right. Don't ask, was that hard? Ask something targeted, like, I noticed the anatomy near callous triangle looked a bit unusual.
Yeah.
How did you decide on that specific dissection plane? Ask about the decision-making process.
That makes sense. Okay, so phase 3 is when the trainee actually starts doing parts of the operation. Progressive independent practice, but under supervision, starting small.
Exactly. This step requires real humility and patience, both from the trainee and the supervisor. You start small. Maybe in a lap cholecystectomy, the junior surgeon does the initial port insertions. Then maybe they dissect the straightforward peritoneal attachments off the gallbladder fundus. You build competence incrementally.
And then gradually take on more.
As confidence and skill grow, yes. They take on more challenging parts, like maybe the delicate dissection around the cystic duct and artery, which requires much more finesse.
And the sources lay out a pretty standard progression for which procedures you tackle, right? You don't jump straight into something complex.
No, there's a recognized ladder of complexity, really designed to manage risk as skills develop. You typically start with diagnostic laparoscopy, just looking around, then maybe move to common acute procedures like an appendicectomy. Then you have the benchmark basic procedure, the laparoscopic cholecystectomy.
The lap col.
The lap col. Only once you're truly proficient and comfortable with that benchmark do you generally progress to more structurally complex things like hernia repairs, TAPP or TT, then maybe solid organ surgery like spleen or adrenal, and eventually the really advanced colorectal resections.
Got it. That progression builds the foundation needed for phase 4, mastering the truly advanced skills and, maybe most importantly, learning how to manage complications when things go wrong.
Yes, because true mastery isn't just about doing the routine case perfectly. It's defined by how you handle the unexpected, the difficult moments. Advanced skills, like reliable intracorporeal suturing, require immense dedication. You have to start on synthetic tissue, practice on foam models.
Hours and hours.
Hours and hours until tying those knots inside the body is reliable, secure, and reasonably fast. Proficiency with energy devices is also crucial here, really understanding the physics, the safety features, the different tissue effects of monopolar, bipolar, ultrasonic energy. They're powerful tools, but you need to respect them.
And then the inevitable happens, a complication. Uncontrolled bleeding, maybe an inadvertent bowel injury. What's the systematic approach to crisis management in laparoscopy?
Okay, the absolute first response, above all else, remain calm. Panic is your enemy. It clouds judgment, and it's incredibly contagious in the OR environment.
Stay calm, then what?
Second, exposure and suction. Immediately. You cannot control what you cannot see. Don't just start clipping or burning blindly. You have to identify the exact source of the bleeding or the precise location of the injury. Clear the field.
Okay, identify the source.
Third, once identified, apply controlled pressure. Use a grasper with a gauze sponge or maybe another instrument or tamponade to gain temporary control and stabilize the situation while you think.
And then comes the big decision point. Can we manage this laparoscopically, or do we need to convert to an open procedure?
And making that call correctly is the absolute hallmark of mature surgical judgment. Deciding to convert to open surgery is not a failure. Let me repeat that. It is not a failure.
It's a safety decision.
It's the definitive demonstration of putting patient safety above everything else, including procedural pride or ego. Key reasons to convert would be, say, uncontrolled bleeding, where your visualization is just obscured, or if you absolutely cannot clearly identify critical anatomical structures, or if you find something completely unexpected that you know can't be safely managed minimally invasively.
Knowing when to stop, when to open up, that's a crucial skill in itself.
Non-negotiable for mastery.
Okay, so if we connect all this back to the bigger picture, it seems the real difference between someone who's just competent and a true master isn't just volume, it's adopting this framework for deliberate practice. Simply doing cases makes you familiar, maybe faster, but doesn't guarantee real mastery.
Exactly. Deliberate practice is different. It's systematic. It's intentional work focused on improvement. First step, set specific goals. You can't just vaguely aim to get better at suturing.
Needs to be measurable.
It has to be measurable. Like in this simulator session, I will reduce my non-dominant hands-wasted motion, the path length, by 15% compared to last time. Or I will tie 3 intracorporeal knots in under 2 minutes each with perfect form. Specific.
And achieving that kind of goal really requires objective feedback, doesn't it? You might not even realize your own inefficiencies.
Precisely. You absolutely must get immediate feedback. If you're just practicing alone in a box trainer, or even in the OR without specific feedback, you risk just reinforcing bad habits, making them permanent. VR simulators excel here, or having an experienced trainer watching you closely, providing that instant corrective input needed to rewire those motor pathways correctly.
Which leads to the idea of prioritizing how you do something over just getting it done.
Yes. You must focus on technique, not just the outcome, especially when learning. Think about learning a musical instrument or a golf swing. Initially, you focus on the perfect smooth mechanics, the form.
Not just whether the ball went in the hole.
Exactly. For laparoscopy, that means performing a task, maybe even slowly at first, but with perfect economy of movement. Minimize any jerky motions, eliminate unnecessary instrument travel, rather than just rushing to finish quickly with clumsy, inefficient movements. Speed eventually comes as a natural byproduct of perfected technique. It should never be the primary goal itself.
And the final piece of deliberate practice seems to be about avoiding plateaus.
Constantly step out of your comfort zone. Once you feel you've really mastered a basic task on the simulator, you have to challenge yourself. Increase the difficulty setting. Maybe deliberately change the port angles to make it awkward. Or, in the OR, consciously volunteer to take on the next, slightly more complex or risky step in a procedure, under appropriate supervision, of course. That's where the real skill growth happens. That's how resilience is built.
So, what does this all mean? It really sounds like mastering laparoscopy is this incredibly demanding, truly lifelong pursuit. It's not just about learning new motor skills, it's a complete professional transformation. You're blending the hard science of anatomy with, well, the fine art of spatial reasoning and incredibly precise manual control, all while under significant visual pressure.
It really is. And it demands intellectual humility, knowing you can always improve. It requires absolute patience, both with yourself and the learning process. And it needs a relentless commitment to honest self-critique. The journey is definitely arduous, no question, but the reward is significant. Being able to consistently provide your patients with the proven benefits of minimally invasive surgery performed with practiced, masterful technique.
Okay, we'll leave you, the listener, with this final, provocative thought to consider, building directly on that need for deliberate practice. If we truly adopt this principle that focuses on the process, the efficiency, the economy of movement, the smoothness of technique, rather than just the immediate outcome, how does that fundamentally change the way a supervising surgeon should evaluate and mentor a junior trainee?
Yeah, think about how we might shift the focus. Instead of just asking, did the trainee complete the cholecystectomy successfully? Maybe the more important question becomes, was their technique during the critical parts, like the dissection or clipping, smooth, efficient, and safe, even if the overall case took a bit longer this time? It's something critical to ponder.
Definitely something to think about. Thanks for tuning into this deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.